Okay, I guess we will start. Good evening, everyone. Respected Dr. Saloni ma'am, members of the Safe Dental Updates, and dear doctors. We welcome you back for our 47th episode of Learn from Our Master series organized by Safe Dental Updates. And been a beautiful journey so far, and we thank all the doctors who are attending our webinars so far and also visiting our platforms like our Instagram page, YouTube channels. We are very humble to see your positive feedbacks. So for those who are attending our webinars for the first time today, I would like to do a little bit of introduction. So we are Safe Dental Updates, a dental platform in which we believe quality education always ensure predictable outcomes for dentists of all disciplines and abilities. Our organization is established based on the observation that the dentistry is complex and requires ongoing learning experience. We conduct various webinars and workshops to enhance the skills of dental professional and guide your dental journey. So without further ado, let us start our series in which our topic of discussion is Demystifying Class 5 Restoration, given by Dr. Saloni. To speak a few words about ma'am, Dr. Saloni completed her MDS in prosthodontics and implantology from Savita Dental College, Chennai. She completed her fellowship in digital dentistry and she is a BPS certified complete denture specialist. She has done numerous publications in the field of prosthodontics, implantology, and general dentistry. And her keen of interest is towards full mouth rehabilitation, smile designing, and complete dentures. So without wasting more time, I would like to invite Dr. Saloni ma'am for today's discussion. So ma'am, please.
Hi, am I audible?
Yes, ma'am, you're audible.
All right, perfect. So, hi everyone. I can see many people. Okay, I would begin with I'm super nervous, but without further delay, I'll begin. Firstly, I would like to thank Safe Dental Updates and Dr. Chanu for giving me this opportunity. And I'm not an amazing person, it's just I'm sharing little knowledge that I have. So, I am a Jen. I'll begin with a little bit of myself. And he is my guru. He is Acharya Mahashraman ji, who always says, "Sapne pure nahi hote, sankalp pure hote hain." Dreams you don't achieve dreams, but commitments help you achieve your dreams. So I did my BDS from Nair Hospital Dental College and my master's from Savita Dental College. And I'm very grateful and thankful to all my professors over here. My journey in composites. So being a prosthodontist, I did choose this topic. I cannot continue without thanking these three people who made a big difference in my life. Dr. Irfan Kachhara, who I call my finishing school. I was with him for a year. Dr. Mayur Davda, who helped me a lot in improving my photography. So today, whatever photos and everything that you'll see are all clicked by me. None of them would be from internet. And of course, Dr. Vishal Gupta, the king of composites, who I did his course and definitely learned a few points here and there. So coming to our topic, class 5 restorations. A bit of theory I'll do. I don't like theory. I'll jump to clinical ASAP. But let's just understand what we are doing and why. This is a nice picture that I got from Pinterest. So what exactly are non-carious lesions? If you see, we have 4 types: abrasion, abstraction, adhesion, erosion. Now, everybody knows them. The point is class 5 is defect in the tooth in cervical region. So for today, our point of interest would be abrasion and abstraction, because adhesion cannot be done by composites most of the times, and erosion is also not today's topic of interest. So let's
Ma'am,
focus.
sorry to interrupt, ma'am. I
Yeah.
think your voice is breaking a bit, ma'am. I think there's
Uh,
a lot of
is it
comments
better
regarding
now?
this.
I'll just check one moment. This is,
Okay, ma'am.
oh, is it better now? Do I keep it here?
The thing is that I think the microphone, the voice is breaking up.
All right, one second. Let me try without it.
Okay, ma'am.
Is it better now?
I think now it is better. I think shall we continue with this and see if anything is wrong, I'll try to interrupt now.
Yeah, please interrupt me, okay? Because I am not, I'm just seeing my screen. I can't understand if I'm audible very well or not.
And now I think the voice is fine, ma'am. I think we can continue.
All right, perfect. So yeah, we didn't miss much, but so abrasion and abstraction is what we will be looking today. Now, what is the difference between the two? Basically, abrasion is both are class 5s, but abrasion is because of any external factor. Maybe the best example would be toothbrushing habit, and abstraction is something to do with microfractures, which is due to the eccentric occlusion, heavy occlusion, which will lead to microfractures in your cervical region and lead to abstraction. Now, this is taken from student. So this picture is just to understand why we need to do class 5 restorations and not just fillings. So if you see in the first picture, they talk about the flexure forces that act on the tooth. Now, both of them are class 5 restorations. Due to eccentric forces, it leads to tensile stresses, and that's how, even if you don't bond it very well, your restoration, it just pops off. And another very important thing in this, if you see the second picture, it describes a flatter cavity that is saucer shaped, which is mostly abrasion. And the wedge defect is your abstraction. So whenever you have abstraction or a wedge type defect, all you need to do.
Ma'am, so sorry again. I think again the problem is still arising now regarding about the voice only. It's breaking up, ma'am. Okay.
How do I do that now?
Is it possible if you can just disconnect and connect it again? Possible?
I'll do that. 1 second. Let me just 1 minute. I'll just join it.
Okay, ma'am, sure.
Can you somebody reply?
I think we can, we'll have to continue our presentation. If anything is there, we'll let you know, ma'am.
Oh God. Okay, I think I'll continue now. Okay, thank you. Thank you, Bhaskar. All right. Okay, so now if we see
the wedge-shaped effect, we need to convert it into saucer-shaped and only then do our restoration. So that's enough for this. I'll just move ahead to important clinical points, which will, because you're giving you so much time, which will help you be a better clinician.
Ma'am, I think the screen is not shared. Can you share it?
I already did that.
The voice is fine now. Voice is perfect now. Crystal clear.
Oh God, I did share screen. I am.
Yes, no.
Fine. Okay. So we have normally heard it's the archer, not the arrow. I hope you understand what I am moving forward to. But don't you think a sharp arrow will only make an archer better? So here we come to our next thing, that is armamentarium. This is very important because many a times people say, "Arey, just do the filling. It doesn't work that way. You need good stuff to do good filling. First in that is your magnification. These are my loops, Admatec loops, but you all can choose any type of magnification, but magnification with light. Without light, magnification is as good as nothing. So light plus magnification is very important. Next, we go to gingival retraction. Now, class 5 cannot be done without gingival retraction because the most important thing in class 5, or why is it tricky? It's because of the overhang that is left behind in your restoration. So these, the blue ones that you see, is my gingival cord packer. It is from GDC. It is non-serrated, sharp and thin. Now again, tools are your personal choice, but I prefer serrated because generally, I prefer non-serrated, sorry, because serrated generally hooks up the cord and it pulls out. That is my personal choice. To each one is their own choice. And cord, most of the times, 00 is sufficient enough to retract the gingiva, but it also depends now on the type of gingiva you're working with. Instruments. Now, opposite instruments, you get a kit, it doesn't work that way. Now, this is a beautiful instrument that I have. It's from Hugh Freddy. But you see how flat and thin it is. And it's also flexible. In next slide, I'll show you how it is used. But you need this instrument for a class 5 restoration. You cannot do it with regular one golden color instrument, Lelia, that is for everything. It doesn't work that way. And this is a brush. It's a silicone brush. Now, many companies have come up with good dental brushes and all, but frankly, this is from Amazon. It works perfectly fine. In 400 bucks, you get a good bunch of 5 brushes. So these are silicone brushes that are used for, I'll show you. Once I do the clinical cases, we'll see that. So this is how you see that tip is utilized, both the ends, and how it nicely sits on the tooth, and it can be used to mold your composite. I'm thankful to this patient. She's my aunt. Next, finishing and polishing instruments. Now, this is actually common for any composite restoration for that matter. But I'll tell you these important points. I don't have a lot of matter written on my slides. So it's better if you can jot it down. Now for finishing, once the filling is done, like once the restoration is done, once you pack your composite, after that, this is the first burr that I use. It's a simple round burr, round tapered burr, long round tapered burr. And it's a blue diamond. Important is low speed. You cannot do it with very high speed because that will lead to nicks and notches in your restoration. It's already a very small space that you're working in. So with slow speed, so that your tactile sensation is better. You have in the second picture, you can see it's a yellow band. So after blue diamond burr, the second instrument is yellow band burr. This is also same long tapered round. And you go from left to right. So from one proximal region to the other. And you make sure that the burr tip is going inside the gingiva. So even if you're scared, like, it's bleeding or anything, it's okay. Gingiva heals beautifully. It's just 1 week. But more important is not to leave any overhang there. So these two instruments are majorly used for finishing. For polishing, you can use Shofu polishing kit. I used the white one after the yellow band from the Shofu kit. And my best and my favorite, like all the, when you see the clinical cases, all the polish that you see is because of the Eve Dicom twists. Now, these are your pink and beige polishing burrs. They are beautiful. The only thing is they have to be used anti-rotation. You don't have to go clockwise. You have to go anti-clockwise. And it has to be used in slow speed and along with water supply because they heat up your tooth. And it has to be towards the tooth. Now, if it's a class 5, you will go from gingiva towards the tooth. Do not go ulta. You will lacerate your gingiva more. Moving ahead, step-by-step procedures. So this was taught to me by Dr. Vishal Gupta, who says, if we follow protocols, if we follow fixed steps, then, every restoration will be consistent, will be predictable, and you can repeat the same result in every restoration. Today, I'll show you some 9 cases. You'll see there are not like, every case is not very different once in the final result. Now, step by step, the first thing is anesthesia. Now, many people say why to give anesthesia, but this slide depicts it very clearly. So when you give anesthesia, patient is comfortable. Patient is comfortable, you will be able to do the procedure very well. It's only buccal anesthesia that you need to give, and 1 ml is more than enough. Like 0.5 also works at times. So even when you pack your cord, when patient is not under anesthesia, patient is very uncomfortable. And then you say cord packing is difficult. If patient is comfortable, patient is not having any pain, then it's very easy to pack your cord. So 100%, my 99% of the restorations class 5 are under local anesthesia. Next is preparation of the cavity, or majorly in class 5, you don't have to prepare much except roughen the surface. Now here comes air abrasion. So 2 things which I would like to say, air abrasion and rubber dam isolation. These 2 things I do not have yet. Now this is something which I look forward in the new year, my resolution to start rubber dam. But that doesn't mean that without rubber dam, you cannot do a good work. So currently, whatever cases I'll show you are without rubber dam isolation. They are with cotton roll isolation, but it works fine. 100% rubber dam is is much better. I will be going to that, but currently I'm not using rubber dam. And air abrasion is very important, but currently even I don't have air abrasion unit, but you can work otherwise as well. So what I do is with your round burr in the cavity portion, can you see the arrow? Anybody can reply? Is arrow visible?
Yes, ma'am.
Okay. So in this portion is what, with your small round burr, very slowly, you just have to roughen that surface. You don't have to make any ditch. You don't have to make any preparation. Just go through it once. That's it. And second most important thing is your bevel preparation. Now, this bevel preparation is irregular. It's long. Now, if you see here, the arrow that you see, the entire blue arrow, you have to go till middle third. You're not cutting here. You're just making roughening it and making a bevel. So it's okay because only your composite restoration should be hugging the tooth. So don't shy away from reducing that portion of the tooth. You need enamel to bond. So till here, most of the times, class 5 restorations, till middle third of the tooth, you need to give your bevel. Next is this is too much theory. The last slide after this, we start with our clinical case presentations. This is very, very, very important, your adhesive protocols. And in this, the most important is your time. First is etching, next is bonding. So how it goes is, first you give LA, you pack your cord, you prepare your surface. Then comes etching. Now, etching, you need to do selective etching only, because at times in class 5, there are deep cavity lesions where you cannot etch. So what you do is you can place a Teflon. Case will come, I'll show there, but you can place Teflon and then etch. Now etching has to be done for 15 seconds. Now generally when we etch, we just etch. I'm very sure nobody keeps more than 5 to 6 seconds. So you have to wait. Those 15 seconds count in your head or keep a timer because timing is important. 15 seconds you have to etch. After that, you wash it and dry it. Now, important thing is when you're etching dentine, you don't have to air dry it because the dentinal tubules, they collapse. So now you have to be careful. Etching in the enamel portion, you can air dry, but dentine portion, you have to use a cotton pellet, or it's called moist bonding protocol for dentine. Or you can use applicator tip, dry applicator tip, and just clean that area. Like there should be no etch left, but no air, strictly no air drying on dentinal surface. Coming to bonding, I personally use Ivoclast system, tetric and ceram. So I have a universal bond. You can use the bond you're comfortable with. Material, I don't get into, whatever you are comfortable with. Now, bonding has to be rubbed. You don't have to dry bond, but you have to rub with your applicator tip for at least 20 seconds. So while you are rubbing, count till 20. Most of the times what we do is dip kiya, tip kiya, ho gaya. It doesn't work that way. No air drying on after applying the bond. Nicely rub for 20 seconds. Go in the dentine portion, go in the enamel portion. When you know dentine is more or cementum part is more, apply there, rub there more compared to enamel. You need to nicely rub the bonding agent with your applicator tip. And once that is done, you put a layer of flow and then you start with your composite packing protocol. That I'll come. Now we begin with finally case presentation. Coming to the first case. Now, if you see, this is a very small defect, but patient complains of sensitivity. So what we first do is LA, then we pack the cord. So here it is only cotton roll. Maxilla buccal anyways, that's not a very big saliva issue. So you just put cotton roll and the cord that you pack around takes care of the fluids in the gingiva. Now, a simple tip or small clinical tip, how do I pack cord? First only, take a small portion of the cord from your container, remove it, and push it proximally. Once it goes down proximally, you have to use your cord packer and go towards the gums from one end to the other end. If you start from buccal, it's very difficult. And in fact, there are high chances you'll push your instrument into the gum. So all you need to do is push proximally inside and then slowly, in this fashion, you go around the tooth and pack your cord. Once the cord is packed, you can see here it's roughened. Here I did not require beveling a lot, but still till maybe 1/3 of the tooth I have beveled. Then I always put a layer of flow that can be even a drop. It is exactly at the junction of enamel and dentine. In this portion where you can see white spots there is where I generally put one layer of flow. Now, once you insert flow, don't just cure it directly. After putting a drop of flow, take your probe, spread that flow, and then cure. There you can see after the flow, then you use your instrument, take very small increments. Now for class 5, you need very small is a half rice, a pellet of rice, half that size. You have to place composite, nicely pack it everywhere. And your packing should be such that you don't require a lot of finishing and polishing. So this first picture is packed slide. And then second, after this, similar, same sequence follows. The blue band burr, the yellow band burr. Again, these burrs, you don't go front and back. You just go from one end to the other end. Like use only one direction because only then your the lines that are formed. So blue band burr generally leaves a lot of lines. So those lines are cleared or polished by your yellow band burr. So always go from one end to the other. And then you use your polishing kit, the Eve twisters, from gums towards the tooth. So there will be bleeding, but after a week or so, it will beautifully heal. And the upcoming cases, I'll show you 6 months post-op as well. So now this, what you see is a carious lesion. This is a proper lesion that is um, like class 5, but with proper caries. Now, how do we go about this? So here when you see, you will never understand the extent of this carious lesion until and unless you pack cord. Now, I have packed cord here and you remove caries. Generally, what I prefer is, in such cases, the last portion, like upper top, I'll use aerator handpiece. But once you reach the bottom, like it's deep, but you can still see soft portion and you're not sure, avoid using aerator there. This is a very important clinical tip. It's better to use your contra angle handpiece with a small round burr, and because that was very controlled. And that when you place there, only the soft portion will come out using that. So that's what I do. And then if there is no exposure, now this is the case where I was telling you where you can use a small portion of Teflon. What you do is at the center of the cavity, you'll place a small square of Teflon, then etch the entire region, wash it nicely, Teflon comes out. After this, I put a drop of calcium hydroxide in the deepest portion of the cavity, if I feel it is very close to the pulp. And then bond, and then the protocol is safe. So you can see nicely it is packed. So when packing only, if you reduce, like here only, before curing, when you're applying your layers, remove the excess. So that in finishing polishing, you don't have a lot to do there. And this is the polished version of the tooth. Again, in 1 week, this heals beautifully. Now, this is sensitivity case. If you see, it's actually not a defect. It's mostly because of abrasion. But patient had severe sensitivity in this. Now, the first thing, what you would do is you can apply Gluma desensitizer. But even if that doesn't work, which did not work in this case, I had to do a filling. I generally avoid doing only flowable. That's, again, my personal choice. I want that one layer of packable composite just to be sure. And in this, you can see I have retracted using Teflon. So that is also a very good option. Totally, again, your choice. But I feel Teflon is difficult compared to cord. Again, this very single layer, thin layer of composite is applied. And the cavity was such, I couldn't do it in 1/3 portion of the tooth. In such cases, you have to roughen the middle third and extend. Otherwise, it pops off. You can see nicely it's extended till middle third and the polished surface. So the basic idea is your restoration should not be identifiable. And this is a very interesting case. Now, patient came with this. Patient had no pain, no sensitivity. But when you see this, I can see there is active lesion over there. We pack cord. See the difference after packing the cord. The importance of cord packing in class 5 restoration. Now, so clearly we can see how deep the lesion is. 100% if this is done without cord packing, you will miss the real portion and the cavity continues from there. Again, other things remain the same. You prepare, you roughen that portion, you make nice bevel, you add composite, and you finish polish. Here I have a photo of post-op. This was after 6 months, but I was making a lower crown for her. And I realized, just see how beautiful the gingiva heals in the upper. These are the upper 2 teeth, the first and second premolar. This is on the day of finishing polishing. And this is after 6 months. So gingiva heals if there is no overhang. If the polish is nice at the margin, gingiva will come and hug your tooth. This is a simple abrasion case. In this, you don't have to actually make huge bevels and all. This just requires a little roughening, and always smoothen any sharp margin if you have, because that will lead to those white lines in the end. Now, if you see here, the 1-4 portion has a sharp margin. 1-5, I hardly prepared. I just roughened it with long burr. But 1-4, the distal margin, I had to smoothen it out. Again, cord packing, a layer of flow, and packable, and that's it. Now, coming to shade, generally I choose shade A3, A3.5, darker hue, because normally your cervical portion is darker than the entire tooth. This is a very interesting case. Patient had sensitivity over here, but it was a very, very small lesion. I was actually in doubts, but then cord pack and see. When you cord pack, how beautifully you can appreciate the entire margin over here, down in the cervical portion. Now, same things you'll do. I've already done cord packing. Patient is injected. So this portion as well, you need to bevel. Now, normally, so many cases that we saw, we never did beveling on the root surface or on the gingival portion. But here, when you see and you have a flat base, you need to bevel that. So in this portion, you will be beveling, as well as, of course, in the cervical portion of the tooth, you will be beveling. So nice bevel, a layer of flow, packed with packable composite. And now at times when you're finishing, the cord comes, it's okay, because already the gap is created. So your finishing burr will nicely go inside and polish. So I generally do not remove the cord. It comes out with your finishing burr. Nice and clean. Now this is abfraction. So here you see how sharp is the margin over there on the tooth. This a very important thing before I proceed with other cases is, when you see such case, you have to be sure it is abfraction. Because if patient is happening through toothbrush habit, it will be multiple teeth. It will not be one tooth. And when there is abfraction, make sure you check the occlusion. Because any amount of filling you do, bonding you do, if abfraction is there and there is continuous eccentric contact, it will lead to fracture. And because if enamel can go, your composite will definitely go. So you have to bond nicely over here, but again, check occlusion in such cases. So here I had to do nice, we can see rough surfaces over here. We can see so many lines, that is roughening. And I removed quite a good bevel because it was very sharp. It was like a base was formed. So you need to soften this region. So don't shy away in giving bevel. Here, I had to give a 45-degree bevel. I may have removed a layer of tooth in this. But do not shy in that, because if you don't do that, it will be like a block that you put and it will pop out. You don't want your fillings to pop out. So nicely you roughen it, you make it smooth. This is proper 45-degree beveling and removing of maybe one layer of enamel. Not one layer, but smoothing it. And then you add nicely, and that is the finish. So basically it has to be one labial surface. Now here, when patient has multiple, this is a clear-cut indication of hard tooth brushing. So just don't see classify bhardo. It has to be, you need to analyze occlusion, very important. You need to explain to the patient that even if I do restorations in this and you continue doing hard tooth brushing, this will reoccur. You don't want that to happen. So again, same, you do cord packing, you roughen the surface, etch, bond, rub nicely for 20 minutes, a layer of flow, packable composite, finishing burn. You see how, so this was one of my initial cases. So now such finish, when you leave, it requires time in finishing. You don't want that. So while packing only, you pack and then use that brush to smoothen it. But anyways, the finishing was okay. Now this is last case Very interesting case and my favorite case. So patient came and complained of sensitivity. Now problem is, if you see like this, it's not actually identifiable. Of course, you'll say this canine, but surprisingly sensitivity was here in the first premolar. I simply do cord packing and see what we find. So if patient is complaining, don't turn your blind eye. Are kuch nahi hai udhar, there's nothing, you'll be fine. No, just go little deep. Just do cord packing. It doesn't take more than 5 minutes. And see, there has to be some lesion beneath. So that's why I call this hidden class 5. So there was this thing, this lesion which was happening underneath your gums. So again, cord packing, roughening, rest steps remain the same. Here, important was diagnosing that there was a lesion beneath. And here you see, again, beveling till middle third. You see the rough surface, then burn, and nice finish at the end. Now, all this is about composites, restorations, but another important factor we cannot forget in class 5 is your soft tissue grafting. Now, when to choose this, I'm not a very expert on this, but I'm grateful to Dr. Nikita Patil. I'm not sure if she's here, but thank you so much she's a periodontist, a fantastic periodontist. She's my friend, and she did courtesy to share her pictures. This is her case. And you see, this is what, if you see in 3-1, there is recession. Now, in such cases, even if I do composite, maybe sensitivity will go, but it's not a permanent solution in these type of cases. So there you can see she has done free gingival graft. And in the second picture is, I think, 15 days later. And the next picture you see where it's beautifully healed. This is post 6 months. But again, convincing every patient for mucogingival surgery, I'm not very sure. If they agree, well and good. I have a periodontist, I call them. If they do, perfectly fine. But it's their field of expertise. Maybe next time Shanuf can keep one person on perio to speak about this. So yeah, that's it. Be the best you can be. I try every day to become better. I'm saying this is not best. Whatever I showed you, maybe I inspire you to at least start packing cord or to at least get a good instrument for class 5 restorations. But for me, I improve every day. My next investment is rubber dam. I need to get air abrasion unit. But yeah, you keep evolving. You keep learning. And thank you. You can connect with me on Instagram. Thank you, Shanuf. Was I audible or I was just talking to myself?
No, ma'am, no. Everything was perfect. It was crystal clear, actually. All went good. So we are going to do a little bit of a question answer session. I would request the audience just to post questions which is relevant to the topic, nothing which is irrelevant to the topic, just relevant to the topic. We'll accept few questions, and if any other questions are there, we'll try to rectify in the Instagram platform. So I'll just see if any questions are there. Let me see.
I think I'll just revise the entire steps. I see that many. So basically, till you see question, Shanuf, I'll just revise all the steps.
Sure.
So first, for a class 5 restoration, first thing is local anesthesia. Second, you do is cord packing. Third is roughening the surface and making your bevel. So basically preparing the site. Fourth is etching. You wait for 15 seconds, put a timer, count in your head. Actually, put a timer or watch a clock. Because when you count in your head, it's like 1, 2, 3, 4, 5, 6, 7, 8, 9. It doesn't work that way. So watch your clock. After 15 seconds, nicely wash it off, dry it. In the dentine portion, make sure you don't air dry too much. You just have to use applicator tip and clean off the edge. After that, you bond. Bonding has to be like proper rubbing for 20 seconds. Take your applicator tip, talk, listen to some song, but do it for 20 seconds. After that, you cure it. You put a layer of flow. Just don't directly inject. After injecting a drop, take a probe, spread it everywhere. After that, you take very, very minute portions, half pellet of rice, composites. So one more clinical tip. Generally, I don't directly take composite from the compute or the syringe that you have. What I do is I take it in your finger, but yes, you have to be 100% sure your fingers are neat and clean. And I mold them a little. So when you mold them and then put on the tooth, it's much the efficacy of which it molds and it spreads on the tooth is much better. So you do that, you apply. Till now, I have not removed the cord. You apply nicely, purely with once you finish application, maybe first you cure it, then you apply second. Mostly 1 or 2 increment is max you require in class 5s. You apply nicely, clean it with your brush, spread. So spreading with the brush is before curing. Huh? After curing, spreading with the brush, no use. You nicely spread your brush, then cure it. Now you use your long, now I'm starting with finishing. So you use your long tapered burr, blue band burr, diamond point. You go from one portion to the other, like from one distal end to the mesial end, mesial to distal, your choice. And that when you do not shy away from going little bit inside. Your cord will zoop karke come out. It's okay. Even it's better not to pull and just go like that. Your cord comes out. Then you put a yellow band burr. Go again in the same direction, maybe twice, thrice. You'll see all the lines formed by blue band are gone. After that, at times I use the white burr from Shofu. Otherwise, mostly it's the two my dipole twisters from Ivoclar. So it's pink and white. Pink is little rough and white is the fine one. Both are polishing only. You use them with water. Do not use them without water. They produce a lot of heat. It has to be anti-clockwise direction and you go at a very slow speed from the gums towards the tooth. So you just go from the gums towards the tooth, from both the ends, from mesial as well as from distal. And that's it. You have a nice class 5 filling. Any other question?
Okay, ma'am. So one of the questions, which bird do you give for doing the infinite bevel, ma'am?
So beveling is again a long tapered burr only, maybe not very long, the short one. Again, depending on the size, it's anterior incisor, I may use the long one. Its burr is not very particular in this. You can use any burr you want. It's the way you put the burr on the tooth. So it is at 45 degrees, and wherever you portion you want to bevel on the enamel, if this is the enamel, you just go like that. That's it. In 45 degrees, just make a bevel. But avoid flattened burrs because they at times might create, nicks and notches. So round, preferably tapered round burr.
Okay, ma'am. Any recommended company, the calcium hydroxide, the one of the cases where you had used a calcium hydroxide, any recommended companies with which you use?
So I have a syringe of calcium hydroxide. I don't do root canals. I have no idea about those materials. But yes, I have one syringe of calcium hydroxide, which is in the syringe form where I can just press and it comes. It's not those 2 tubes where you mix and put. At times when I don't even have calcium hydroxide, I can use flowable GIC. But again, this will be sandwich technique. But GIC when I use, it is again only on the inner portion because GIC is soluble. So I avoid using it. But if calcium hydroxide is not there and I'm close to the pulp, then I might use flowable GIC. Ino-Seal. I think it's from Pre-West. I'm not very sure, but it's Ino-Seal. It's syringe from GIC. So you just have to play with the syringe and it comes at the drop where you need. Oh, and one more, sorry, I forgot one very important thing. Once you finish your class 5 finishing polishing, I also put a layer of jelly, KY jelly it's called. You get it at any medical store. I put that and cure on. That is a must do for every restoration. Once you finish polish everything, put a layer of KY jelly and cure it.
What size cord do we use and how do we decide?
So majority of the cases, it is 00 that works. But if it is very thick, so basically how do you decide is, you see if the gingiva is very thin and you can see through the tooth, then you can go with 000. If gingiva is very thick and even after putting, 00 cord, you can't see the margin, then you remove that and you put single zero. But most of the times 00 works. If I've done 50 restorations, maybe 40 I've done with 00. In 5, you need 0, and maybe in 2, 3, you need 000.
How to control bleeding which occurs sometimes while placing the retraction cord?
While placing the retraction cord, generally bleeding doesn't occur, but you can use hemostatic agents. So you just, you can dip your cord and, yeah, again, now placing gingival cord, there are two ways. If you feel there is a lot of bleeding and stuff like that, you can dip your cord. I generally do in a hemostatic agent, you dip your cord and then you pack. And I generally don't like dipping my cords because then I feel cord becomes very slimy and it doesn't go. It just pops out. That's again my personal choice. I like dry cord because when I place dry cord, but you have to be very slow. So whatever fluids are present in the gingiva, the cord soaks. So that's the logic I use, and it works fine for me. But in case there is bleeding, after you've packed cord and you still feel there's bleeding, just put a drop of LA, put cotton, and wait for a while. Don't do everything in 5 minutes. Just wait, in 2, 3 minutes max, bleeding stops. And then you continue with your restoration.
Okay. Do we need to etch the beveled margin or just the bonding agent is enough?
No, 100% edge, 100% edge. 3M and Ivoclar have these bonds which they say you don't need to etch. But enamel especially, dentine you don't etch, it's fine. It's doable. But enamel, I personally feel you need to etch, especially the bevel margins. Why are you beveling? Because it opens up a lot of enamel cords there, or enamel prisms are opened up. The surface area increases. So you want maximum of bonding from there. So 100% etch at least the beveled margin. Even if you're not doing the dentine portion.
Okay, I guess we will wind up this session, ma'am. So if any other questions is there, we'll try to rectify it in, obviously, ma'am is having a Instagram platform as well. You can contact ma'am through Instagram and you can definitely check out her cases as well. So thank you so much, ma'am, for sharing your knowledge
Thank
and
you.
expertise when it comes towards managing a deep class 5 restorations. So surely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed. So thanks to all the doctors for patient listening and your participation for this webinar. And I hope all of you will depart this session with positive, confident manner. So once again, ma'am, thank you so much.
My pleasure. Thank you so much.
So it was a wonderful and informative discussion, and we really appreciate your valuable time given for us for this series episode. So I would request all the audience do check out our ma'am's Instagram page where you can appreciate her clinical works and do follow her. And to know more about our upcoming webinars and workshops, please do check out our Facebook and Instagram pages. And if anybody has missed out any of one of our previous webinars, you can check out our YouTube channel as well. And I would suggest to please subscribe also. So thank you all and have a great night.